All right, greetings everyone. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around our country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared on our show can be applied at your organization. We believe that this strategy of finding a bright spot and cloning it is the most effective way of improving healthcare in our lifetime. Our topic today is equity and timely access as a STARS strategy. Health plans are acutely aware that they are measured and graded on quality, experience, and health equity more than ever before. Their biggest challenge is to directly impact those areas. So we have the perfect topic to cover today. We have the perfect panel, and we have the perfect sponsor. Our sponsor for today's episode is ReferWell. They help health plans advance health equity by scheduling underserved members for the care they need, be it medical care, gap appointments, or through your community partners. We have a terrific group of experts in front of you today that make up our roundtable, and they are looking forward to sharing with you successes and bright spots at their organizations. We've incorporated many of your questions that you submitted upon registration to the live event into our flow today. It is going to be really tight on time. I know traditionally we take some questions from the Q&A module. I encourage you to do that, but I'll be honest with you, we'll be lucky to get through more than one or two from the Q&A module today. What we did try to do our best to take as many questions that you submitted upon registration and get them within the flow. We just have so many important topics to cover today that we incorporated in from both our knowledge, the market asks, and of course, your questions upon registration. So let's get started. Oh, by the way, I forgot to mention this. If you want to get a sense of the expertise that you're about to benefit from, I encourage you to click on the link for your live attendees that Sherry Keels, our producer, just put into the chat. And for those of you who are listening by the podcast, whatever app you're in, within the description of the podcast, we will put the link to the bios there as well, so you can get a sense of the incredible people you have in front of you today. All right, let's start. And I'm going to call this our strategy and star segment. And I want to start with Elizabeth Benz, our Vice President of Clinical Quality Integration at Network Health in Wisconsin, and Ali Tusac. I hope I got that right. Yeah, I got that right. Ali, right? She's the Director of HEDIS and Data Analytics at Priority Health. So I'll start with you, Elizabeth. How are you maintaining that 5-star rating that you have at Network Health? Look, what is the secret sauce there?
Yeah, well, thanks so much for having me here today, Eric. Excited to talk with you and the other panelists about how we can collectively provide better care and outcomes for people across the United States. You know, at Network Health, our STARS approach is an organization-wide approach. It touches every VP, every chief officer, and every health system that we contract with. As I mentioned, not only is it an organization-wide focus, but it's an organization-wide investment. From our board to our CEO on down in our organization, we are all aligned with 5 stars as our goal. We invest in service for our members, for our providers, for each other. We have aligned incentives based on HEDIS and CAPS with our integrated network. We maintain an agile focus throughout the year, so we are constantly adjusting our approach as new data comes in. We look at data from our health information exchange, supplemental data from our providers. We're doing ongoing year-round medical record review, which allows us to have more real-time data and to be nimble and shift our focus towards where our members need the most support and to help drive those outcomes. This also helps avoid bottlenecks at the end of the year with our members in terms of people trying to get in for certain services that can impact your CAPS results for access to care. If we're getting people in and monitoring throughout the year, then they're getting timely access to the care they need. One of the other things is, you know, we've really been working on our approach since 2017. And so for plans who may be newer and evolving their approach, we've spent years building that trust with our providers and our provider systems and building that value within our provider system networks. We have, deep dive monthly meetings. We have quarterly joint operating committee meetings with our providers focusing on the areas of most opportunity For example, recently we've been working with our providers, as I'm sure most of you are, on your controlling blood pressure measures and really helping with providers understanding when someone's rushing in for a doctor's appointment and you get that initial blood pressure reading, if it's really high, have someone take a second reading at the end of the visit, because the person's going to be more relaxed at the end of that visit. And so you're going to always count that last reading. We're really fortunate in Wisconsin is that our health systems are committed to quality outcomes. And so health system leadership is engaging and training with their departments on a monthly basis, educating them about areas for opportunities to close gaps and improve quality outcomes, and also engaging in that one-on-one training with providers at time. As I mentioned as well, internally, we have vice presidents leading every category within the STARS program to help drive peak performance for our clinical health plan operations and overall member experience measures. So it is a full team effort and aligned effort here at Network Health.
All right, let me try. I summarize. I'm taking good notes or trying to take good notes. Elizabeth, I have 7 things I captured here. And if you could just cover me here, just for the audience, see if we got this right for everyone. First is everything starts with the entire organization has this 5-star focus. So culturally, that's your North Star. That's what everyone is thinking about when they show up to work. 2, you've aligned incentives to those 5-star goals. 3, you have a very agile focus. So you've designed the organization so they could be very flexible. And I think that what I listed as a 4th separate thing is you're continuously measuring so that your agile focus you could be flexible as you see the different measurements. The 5th is you have a focus on access, which is good because that's the title of our session today. 6 is you have a very tight collaboration with your providers on star rating alignment. You mentioned controlling blood pressure as one example. And the 7th is your business organization is tied to star ratings as a category. So you're organizing the business and the business leaders tied to the categories that CMS puts out there. So those are the 7 things I just captured. Is that directionally accurate for those who are listening?
Yes, absolutely, Eric. You've captured it correct.
Great. I want to get another perspective. So let's move over a couple of states. Got a very Big Ten theme to our show today. We'll move over to Michigan. And we'll bring in Ali Tusac, who's, again, Director of HEDIS and Data Analytics at Priority Health, another 5-star shop. What's your secret sauce on maintaining 5 stars, Ali?
Absolutely. Well, hi, everyone. So happy to be here. First off, I want to say Elizabeth did a fantastic job with kind of bringing to light some of the things that are really important when trying to obtain and maintain 5 stars. So having that provider collaboration, ensuring that you are in fact collecting all of that, additional HEDIS data, not leaving a hit on the table is so important. And then, beyond that, also taking a step further with focusing on health equity when you are looking at HEDIS, right? And gap closure. So at Priority Health, not only do we focus on a culture of quality and an understanding of 5-star for our Medicare and all of our lines of business, really. But we also have a health equity approach too. So at Priority Health, we have a health equity committee. It consists of cross-functional teams from across the entire organization. We're coming together and discussing the things that we're doing that impact access, health equity, HEDIS. We've created an entire library of programs that are currently happening at our organization that is accessible to members of the team. And so with that, we've also created are currently creating a dashboard of metrics that we find important and show our progress towards health equity and closing gaps in a way that is impactful to our membership. That dashboard has 4 domains in it. So clinical health outcomes, member satisfaction, data collection, as well as staff, provider, and member information. So the first being, having clinical outcomes that are a focus for your organization that show your progress towards health equity. So things like disparities in low birth weight, disparities in diabetes care and control, disparities in controlling high blood pressure measures, and having that readily available and frequently updated for the entire company to see and presented at our town halls that we normally have every month. Member satisfaction, so stratifying member populations based on what is their experience that they are having, based on race and ethnicity, based on region that they live in the state. Are they experiencing care the same way? Are they accessing care the same way? Do they feel they're accessing care the same way? Data collection around, Z codes, SDOH information, and then also looking at our staffing and our providers. Do they reflect the community that we serve? So in addition to all of the things, Elizabeth had mentioned, also having that health equity kind of perspective has helped us obtain and maintain those 5 stars.
Let me see if I might have missed the 4 things on the dashboard, but let me raise it up. So the Health Equity Committee seems to be core to the culture around equity and access, cross-functional, and then similar to what Network's doing as an ongoing measurement. You have a dashboard with 4 categories that we're looking at. Could you repeat that? I don't think I got this right. So clinical outcomes. I had clinical outcomes. You used the prenatal on disparities in CV care. You had member satisfaction.
Yep.
Ethnicities, data collection, or is
Correct.
that? And then staffing of the providers and members, and do they represent the community that you're serving?
Correct.
Those are the 4. Okay, I got it. Tell my mom that I'm doing better than I did in school. All right. Something I forgot at the onset, folks. One of the reasons we're covering this topic, and you'll see we're going to be covering topics related to this throughout this month, is based upon the feedback that you've been providing us over the last, 10 years, but certainly the last 3 months that we've been collecting data from all you. And we collect that feedback by way of an email that we send you 45 minutes into the show with a link to a Survey Monkey. It takes 2 to 3 minutes to complete. It's mostly multiple choice. And it allows us to have a really good North Star on what you need covered. We don't take the hour you spend with us lightly. We need to provide value to you. So be on the lookout for that survey. Please give us the 2 or 3 minutes to provide us with your feedback. I'm going to bring in now Brenda Schrader. She's the Vice President of Customer Experience Strategy at Metroplex Health in New York City, who just earned their 4-star rating. So we've got a bunch of rock stars here as far as Medicare stars go. Brenda, how did you get up to 4 stars? Tell us a little bit about your overall strategy and what got you there and what you're going to continue doing.
Thank you for the question, Eric, and really an honor to be here to discuss CAHPS and stars alongside my fellow panelists. Our Elizabeth shared this a little bit earlier. For us specifically, we pride ourselves at Metroplex Health on our mission for serving New York's underserved. We're very conscious of the healthcare disparities and are really striving to close those inequities. And in our mind, that customer experience that each of our members receive is a critical part of reducing those disparities. So our approach to getting to that 4-star was really focusing on our CAHPS. We had really excellent quality ratings. Where we really needed to make an effort was around the customer experience. And customer experience strategy as a function is relatively new. And over the last 2 years, we have been empowered by senior leadership to work cross-functionally within the organization, really open lines of communications, bring down silos. This empowerment and this cross-functional engagement really was at, I feel, the root of communicating and solving problems as they came up, quickly and efficiently. We set out some intentional CAHPS trainings across the organization, but we did that in very small groups, often with 2 or 3 people, which really allowed us as a unit an opportunity to go beyond routine training and spend time with our frontline and really get to learn about what their day-to-day reality is, whether that's the challenges they're facing, what they're hearing from our customers. This then opened up those communication channels to build trust and empowerment. And then when there were problems that were actually arising, a lot of our frontline colleagues were able to directly reach out to us to share that, they were hearing feedback from customers about in one instance, their flex cards not being available on time, or issues that they were encountering. And what we were able to do is almost immediately mobilize the organization, elevate the issue, and get it resolved within 24 hours. That sort of cross-functional collaboration was really at the heart of what we feel led us to continue to really impact our customer experience and our CAPs. Everybody became unified on what the member felt, what they needed. We all worked alongside a common theme and a common story. We were ensuring that we were sharing any issues that the members were experiencing pretty much as they were arising, and really ensuring that MetroPlus as an organization, regardless of who was speaking to the customer, was overall providing an exceptional customer experience. That's really at the heart of the effort that we made around CAPS, which helped us go to 4 stars for the first time this year.
So like network health and priority health, there is a top-down kind of engine that has to be in place. I would define what you just said as sort of like an overall strategy around empowerment, and what that allowed you to do with your focus on CAPS was allowed to get a lot of information from the front lines and build an overall feeling of trust and empowerment within the organization. That created a fluid feedback track for you. Now, you mentioned this flex card situation that you were able to solve very quickly. Could you just explain for the audience what a flex card is at a high level, what the problem was, just so there's some more context behind that story?
I think it was our first time offering these cards, this benefit, and it was just growing pains. It was communication, and our members were asking us questions on how to use the cards, what exactly they needed to be doing. So we really ensured that we were escalating the issue quickly with our leadership team, partnering with the vendor, ensuring that the communication almost instantaneously went out to our members, and unified what we needed to be sharing as an organization when the members were calling in. So everything was mobilized to go towards the same goal. As with the panelists here, we have so many different customer-facing parts of the organization. We want to make sure that communication is spread across, so every member is hearing the same message. They're hearing the same guidance. They're hearing, exactly what they need to do from one person to another is almost consistent all the time. So that's really what we worked on. And I think it's that rapid resolution. That's just an example, but there were a lot of cases where you can really use that rapid resolution to ensure that the member feels that they're important, their issue is being heard, and the issue is being resolved really quickly.
Yeah, I love that. So we're gonna switch over now a little bit next segment, sort of around HEDIS and strategy. But before we do that, I want everyone to write down, if you have a pen, or type it in, August 24th and 25th. And that is Bright Spots in Healthcare's first inaugural, I guess that's redundant, inaugural in-person payer and provider roundtable event. We're calling it Whole Person Care Innovation. It's called Bright Spots in Clinical Models and Consumer Engagement. It's being held August 24th and 25th this summer, right here on the shores of Boston Harbor at the Marriott Longworth. This event is going to be unique in 3 ways, folks. First of all, it's for payers, providers, CBOs, and our select sponsors only. So it's going to be small, intimate, and just with sort of organizations like you see here on the panel today. 2, we have no formal presentations or PowerPoints. I'm going to repeat that so you make sure you didn't hear that incorrectly. We will have no formal presentations or PowerPoints. And third, we're dividing the 2 days into 5 sessions. We're going to be covering health equity and social determinants. We're going to be covering consumer engagement for hard to reach members. We're going to be covering local as a strategy. We're going to cover whole person care models and virtual care, and finally ROI modeling. And each one of those sessions is going to be launched by a plenary panel like you see here before you today, except that it will be live. It will be moderated by yours truly. It will be represented by the primary market payers and providers. And then we will break everyone in the audience and on our panel into roundtable discussions that will have assigned trained facilitators at each with 2 or 3 specific questions to address during those discussions so that you could have meaningful two-way discussions with your peers around the topic. And then we'll have some report outs and repeat the process in between food and drink. And now, why does that matter to everyone? Well, as a leader at your organization, it is so important when you leave to go to conferences like this that you walk away understanding exceptional ideas or new strategies that are being deployed around this country and how they're working, and then determine if those bright spots can be applied at your organization. And so at the very least, these discussions are going to enhance your thinking and how you could approach health equity and consumer marketing and clinical modeling and ROI. And this is really just hard to do at big conferences. It just is. You sometimes get involved in these conversations, but I want you to walk away from, if you attend this meeting with us and join us in Boston in August, with a lot of information that makes you more valuable to your organization and allows your organization to provide better care to your members. So I'm going to have Sherry Keels is going to post both a link to see the brochure. We're still producing it, but we already have some incredible panelists confirmed already. Secondly, if you want to register to attend and you're from a payer, provider, or CBO, we have a pre-registration rate for the month of February if you want to take advantage of it. And if you are a signature sponsor like ReferWell or an organization that hasn't worked with us yet, and you want to learn more about how to get involved, just either email me at eglazer@sharedpurposeconnect.com, or you can simply DM me on Zoom right now. Or if you're listening to the podcast, just email. All right, let's get into HEDIS and strategy. And I want to talk about how important health equity is to reducing gaps in care. So I'm going to bring in Gene Huang. He's the executive chairman at ReferWell. Gene, can you provide us with an example of a health plan that is focusing on access to care as a strategy to reduce gaps in care, and maybe how they're executing, and maybe share some results with us?
Yeah, hey, great, Eric. Thanks for having me on the program, and it's wonderful to see 4- and 5-star plans doing all this great work. I hate to admit I'm so old that I was running MA plans before they were called MA plans, and before there's HEDIS, gaps, and stars at all in the early 90s. What ReferWell is able to do is it's a tool that we're able to provide to health plans to more precisely and effectively reach underserved populations. So because we are able to provide scheduling, what we've done for a health plan in New York is we've made our tool available so that we can target underserved populations to close care gaps. Particularly, underserved populations particularly have problems accessing care, and oftentimes don't know what care they need to get. So by targeting those populations and using our tool to be able to schedule them, we very effectively get them to care. So what we've done is focused on specific care gaps, starting with colonoscopies, but that's morphed into being able to help more and more people with broader sets of needs. So we've been able to disproportionately reach the underserved because our tool is very effective in getting them scheduled. So we use care navigators, we use data provided by the health plan, and they allow us to precisely target those who actually need the help the most.
How does the health plan that you're referencing, how do they ensure that when they're scheduling an appointment, let's say for a member, that they're getting that member to someone who's in network and convenient to them and has appointments available? Just a little bit of color.
Great question, Eric. And that's exactly what a really good scheduling tool will do is we'll be able to actually get schedules of targeted doctors. We can actually prioritize doctors that are higher quality, more accessible, all of that. So we can target those doctors and we make those available live at the referable moments when we can actually engage the patient and get the patient's commitment to go to a provider.
I'm going to double click on the referable moment later on. I want to figure what that is, but we'll get into that later. Now, you guys, I believe, and tell me if I'm wrong, because in preparation for this, your team sent me a 2-pager outlining, I think it was this case study. Am I correct?
Yeah.
Okay, so there's a 2-pager that it's on how it's both, they're focusing on MAs and duals, if I remember
right,
reading
yep.
correctly. And it's really interesting, folks. So this is sort of how this case study includes how health plans define success, how this health plan defines success, the results, and the overall blueprint and timeline on how they achieved all those things. It's short, it's informative, it's got like lots of graphs. It's like a USA Today sports page, which I really miss. And I'm happy to email it to everyone if you want. So folks, I'm going to have Sherry, why don't you throw in a poll and I'll just email after the show everyone a copy of this 2-pager that just basically outlines this case study. You guys always ask me for notes to the show. This is perfect notes to that case study if you want it. And if you're listening to the podcast, just email me or message me on LinkedIn and I'm happy to send it to you, easy peasy. Let's stay on this topic around gaps in closing gaps in care. Allie, what is Priority Health strategy and approach to closing gaps in care? Let's get a different perspective.
Sure. Thank you. Well, for us, I think it's important to set a focus. We cannot do all things at one time. So we have to kind of focus our efforts, right? So at Priority Health, we take a population health approach to HEDIS. Gap closure, we use a 7-step process to target populations for intervention. 3 really important steps in that process include data integration. So making sure that we are integrating as much data as possible internally. Some health plans suffer from having a lot of different systems, right? Where data is housed, looking at external data to help drive decisions and analysis as well. And then the next steps, another step that is very important is analysis of the population and really understanding the nuances of the populations. As you mentioned, we're in Michigan. That includes Detroit, Michigan. Detroit specifically has a lot of challenges, both access challenges, transportation challenges, access to grocery stores is also, there are food deserts within the city of Detroit. And so understanding the nuances of the populations and some of the barriers that they have to care is really, really important. So we gather that information and then we have targeted interventions as an additional step within that process. And so making sure that we are getting feedback ahead of those interventions and then also afterwards from not only our members, our providers, community partners, and organizations, as well as internal staff. And then completing those evaluations on those is really important. I think sometimes health plans struggle with doing a complete and full evaluation on an intervention to ensure that it's truly impactful, truly effective, and kind of having that full PDSA, cycle. It's invaluable. So that's kind of our approach when it comes to drilling down into populations in order to effectively make change.
So you're doubling down on a sophisticated data analytics pop health strategy here. You mentioned targeted outreach. Can you give us some more color on that? Like how does that work? What does that feel like?
Sure, absolutely. So depending on what the data shows us as far as needs, we do have a concierge team for our Medicare line of business that conducts outreach. So if it's identified that maybe just some telephonic outreach is required, we have a team that can do outreach to those members and assist them with closing care gaps by helping them schedule appointments, and complete follow-up care. And so answering any questions, sometimes, members may not know what the next step is for them. Healthcare can be confusing, right? So having kind of someone to help them along the way is extremely important.
I'm going to transition over to, I know this is all interrelated, but what I'll call our equitable care kind of segment here and bring back Elizabeth Benz, who's the head of clinical quality integration at Network Health. Elizabeth, what is, unique to the, Network Health's 5-star approach to driving towards health equity?
Yeah, Eric, as I mentioned earlier, everyone across the organization has a hand in our quality outcomes. So in alignment and parallel to our present day STARS work, as Allie mentioned earlier with Priority Health, we have a health equity committee as well. And this comprises an organizational wide cross-functional teams that are focused on our health equity work. work. Moreover, our health equity strategies are a standing agenda item in our provider joint operating committee meetings. So we're not just looking at what are we doing internally, but leveraging our providers who are going to have the most trust with our members at that front door touch point to figure out how do we best work together to meet the members' needs. It's not one department. It's not a person's job. It's incorporated into all of our jobs. And everyone at the organization is aware of the importance of health equity for our members. And to Brenda's point earlier, our mission is to create healthy Wisconsin communities. And that's what we're doing in this work. At present, as Allie mentioned, we're focused on gathering information and really looking at our data, but also incorporating the member's voice along with the data. So as we're gathering information on member social determinants of health needs, we're aware that just because someone screens for something doesn't mean that that's what they want or need at this point in time. And that's really important so that we're not putting forward interventions or benefits that might not actually help the individual on the other end. Another thing that we're doing is we're looking at our data to identify disparate outcomes outside of HEDIS and layering that information along with our health equity focus. So for example, looking at things like our volume of appeals and grievances and looking at, are these members in the health equity index? Do we have a larger volume of appeals and grievances? Engaging in high touch outreach to those members to better understand if there's opportunities to improve health literacy, understand where they're coming from. As Brenda mentioned, engage them in the solutioning of the issue so that we ensure that we're meeting their needs. And what we're finding by taking that approach is from a net promoter score, we are seeing the immediate responses of after we reach out and engage with the members, they are more likely to recommend us to a friend because of this high touch work that we're doing. So it's really helping us as an organization understand the full picture. I think you've got your data component and then you have the member perception component, but you really need to be mirroring those two, in particular with the health equity work, to make sure you're meeting people where they're at. And that's part of what we do. And our teams are engaged in our communities, which helps us as well.
Great. Brenda, you mentioned your initial answer that, Metroplex Health was focused on serving the underserved in New York City. So I'd be remiss if I didn't ask you what you guys were doing to drive towards more equitable care in New York City.
Yeah, thank you for the question, Eric. Something really near and dear to all our hearts at Metroplex Health. We've all experienced this over the last couple of years. Several members who are high risk, either not making appointments, maybe sometimes because of the digital divide, with maybe telehealth appointments at that time only being available, and maybe some discomfort in doing telehealth. We've got a lot of examples, but one particular one comes to mind. We had a pregnant member who was considered high risk, and she had not had any prenatal appointments. And because she did not want to attend a telehealth appointment, and she couldn't get any appointments near her, she actually reached out to our call center. We had actually put in place an escalation mechanism, something like you would call it maybe a tier 2 call center, with colleagues who were really experts in tackling 360-degree level of issues, really able to work across different parts of the organization. These expert consultants were really able to work with our member, understand her concern, work with empathy to ensure that they were meeting her where she really was, ensuring that we were incorporating her voice in being able to find the kind of provider she would really be comfortable with. And while she was waiting for her appointment, we were, because of these interactions, proactively outreaching to her and other members like her. We were actually able to convince her to join her telehealth appointment so she could at least in the meantime speak to a physician and get kind of started. That kind of approach of being really honing in and making sure that we're there for the people that need us more. And we tailor our approach to how we work with them. That's been something that's really important in bridging some of these gaps in maybe equity that we experience. For example, our Medicare membership is about 30% Spanish speaking. So we are very intentional about bilingual call center representatives, really culturally mindful about how the communication and engagement happens, ensuring that, the way different cultures speak authentically, that we're able to mirror that in our communications. All of that has really been part of our approach to engaging towards equitable care.
I love that story. So the key is having that bilingual kind of call center functionality and that overall, I'll call it sort of cultural mindfulness to be able to apply that to that story, that woman with high risk. That's how it all comes together, it looks like. I love it. Let me, folks, I want to move over and start talking about how we make sure we get folks access to the right care and we navigate them through the healthcare system. So we're going to talk about that now. Before we do that, I want to just give another shout out to our friends at ReferWell who are supporting this episode. For those who might have joined us a little bit late, ReferWell helps health plans advance health equity by solving the problem of scheduling with a focus on helping your members who are often not getting equitable access under the services they need, to the services they need, whether it be medical care, gaps in care appointments, or through any of your community partners, services like transportation, assistance, nutritional counseling, mental health services, and other CBO offerings. The data shows that ReferWell has a solution that is actually impacting in a very positive way members who need the care the most. And they have care navigators who find the perfect match, that referable moment we'll get into later on in the show, when a member is leaning into their own care and they are able to schedule that member over the phone. It's a proven process that provides better access and experience, CAP scores, for your members and better overall quality performance as it relates to gaps in care and the clinical measurements that you are beholden to. So check them out at referwell.com. They've been great to work with on this show. We're going to be working with them on a couple of other shows throughout the year. Great partner and a really valuable service. With that, Gene, I'm going to bring you back in because I know maintaining quality is so important to star ratings. And I want to talk about how do you see health plans providing both timely access through this enhanced scheduling that you alluded to earlier, but gain access to high quality providers as well?
Great. Hey, thanks, Eric. Great question. So as I mentioned earlier, we're able to reach to specific members when we're given a list. But the question is around what's the list, the list we have of providers that we send members to is usually based on the network that's provided by the health plan. But as many of you know, the network directories have errors, and so we need to make sure we're scheduling people to the right doctors. So we do a lot of work to make sure the network directories are really correct. We correct errors in them. We have data available to help correct directories. But also, you need to know that every referral is effectively a search, because you can't just refer a patient to anybody. You've got to refer a patient to the right provider. So that's the right specialty, the right subspecialty, somebody who's available, convenient, and it also allows health plans to layer in a narrow network. Obviously, not all doctors are the same, quality. The top quartile, the evidence shows top quartile doctors may be 5 to 10x better than the bottom quartile doctors. And so if you can start to move patients to the top quartile docs, you'll have really moved the needle on improving quality. And if you're targeting the disadvantaged population and driving them to better quality doctors, you're by definition going to really improve health equity.
Let me see. So basically, in order to get those patients' gaps in care filled, and obviously to drive that better trust between the health plan and the member, we're going to rely on data to make sure we're doing a much better job matching.
That's
I don't
right.
want to call it a dating service, but and using that narrow network that the plan has already created, trusting their narrow network and their quality doctors there, and then be able to work with other data sources to validate that network and then help that health plan ensure that that network's being leveraged to the
That's
maximum.
right. Exactly right, Eric.
Okay, love that. What about, so let's actually continue to stay on this topic of creating quicker access. And I'm going to bring back in Ali Tusac from Priority Health. How are you doing that? How are you guys in Michigan providing better and quicker access, Ali?
Yeah, so thank you. That's really important. So for this, we are working really closely with our providers and ensuring that our provider network is where it needs to be. We are frequently assessing the provider network and not trying to just meet ratios and minimum standards, but exceed them as well. Also looking at our provider network to make sure, again, that it's reflective of the community that it's serving. So it allows our members to feel more comfortable in approaching a new physician or make it easier to find a physician that meets their needs. In addition to that, we also are meeting people where they are, right? So not everyone can easily make it to a doctor's appointment. So having the options of virtual care is extremely important, but also home testing. I know there are a lot of health plans that take advantage of that, right? So diabetes, A1C home testing, colon cancer testing. And then we also have a vendor that does in-home assessments. And at that time, they can also collect those samples and complete those services to help close those care gaps. In addition, we also have we last year actually pushed to have our behavioral health access increase. So what we did is we created a zero cost virtual visit for behavioral health visits. We found that to be extremely important and an uptake to be very good. So we greatly increased the accessibility of behavioral health visits in that manner. Additionally, we're doing outreach to members from our pharmacy team to help close medication gaps and kind of get them into the doctor and fill those prescriptions as well. And then I mentioned earlier our concierge team too. So they're doing targeted outreach to members to help assist in gap closure, kind of remove barriers when it comes to scheduling, where to go, what's next. And they also connect them with social resources too as needed. So if they're saying, well, I don't even know where my next meal is coming from. I'm not really worried about, getting my A1C checked. They can help address them with those social needs too, which is extremely important. So.
I love that. So there's a question. I don't want to go down this rabbit hole completely, but you already kind of opened it up for me. So, there is this question that I know a lot of audience members are thinking about is like, how important is virtual care to your whole equity approach? And you alluded to it with mental health. So can you speak a little bit to that? We'll touch upon it briefly and how that relates to your concierge approach to navigation and see if that can maybe give some color for the audience and sort of what Priority is thinking about with virtual care.
Yeah, absolutely. I can't give too much information on it. I'm just not the expert in it. But I will say that making virtual care easy and affordable is extremely important. We see that when things are zero cost and very easy to access, members are utilizing those services. Even someone mentioned the technology gap and that kind of thing earlier, but if you are allowing or giving members the opportunity to utilize virtual care and having it be low cost or free, you will see that they will tend to use it. And using concierge to help them with that as well is a great option too. So having the concierge team educate members on the process for setting up a virtual care appointment, we see that our members are having some uptake with that. So
great. Thank you. So I mentioned earlier, folks, that, we listen to everything, all of the survey feedback you give us whenever you attend a live show. And that survey probably is coming right into your inbox in the next minute. One of the things we're hearing is that this topic around social risk, virtual care, equitable care is obviously top of mind to everyone. And so we've scheduled our next two live episodes. Thursday is 12 o'clock. We have two coming up in March, one on mitigating social risk to achieve higher star ratings. The other is success stories around virtual care enrollment and engagement. So what we like doing for all of you is rather than having to type in the registration form to attend live, if you're listening on your podcast, you can come onto the website and do this. If you're here on the live show, rather than making you register again, if you want to come to one or both of those episodes, we'll put up a poll for you and we'll register for you. So you're automatically registered to come to our next two live episodes. There is going to be next week, I am doing every so often, I'll do just a traditional recorded episode. I'm going to tell you about that in a little while because it's a little bit of a different show, but I want to tell you about that separately in case you're interested in that, but that'll drop into your podcast feed unless I decide to do it live. That's why I want to ask you your feedback on that. But if you want to come to the next two episodes, there they are. Gene, I want to bring you back in because community-based services has been mentioned a bunch, and I want to get a sense of how health plans are managing. I could get a sense of how they can manage into their narrow networks, but how are they making referrals into CBOs and how's this being scheduled? It sounds like a difficult process.
Hey, great question, Eric. I think a lot of health plans' approach to CBOs and SDOH benefits is to go get the network. Obviously, you need to get providers of those services to be available and to contract rates with them and all that. So that's the first step. But oftentimes, health plans don't go beyond that. They don't actually go to actually reach into the these disadvantaged populations and help them really understand what they're qualified to get and then schedule it. So, the passive approach is necessary, but not sufficient. Getting a network, getting all this, printing a directory of those, maybe sending people, something to let them know what's available. But it's really when you start to engage a population and target a population that is not accessing those services or who likely have problems with those, accessing food, accessing transportation, and reaching out to them and engaging them in a dialogue, in sometimes a risk assessment where you can understand what their needs are, and then be able to immediately schedule and get them qualified or get them scheduled. Oftentimes, some of these things have, qualifications you got to have, maybe there's a income qualification or maybe there's some, something else. And a lot of people don't know how to navigate through that, but ReferWell can actually make those appointments, can actually set those people up. So at the end of the call, they're actually signed up for these services, or somebody will outreach to them to finish the process. But rather than let it be passive, we make it very active and very targeted.
Great. I want to bring up this referable moment now thing. Before I do that real quick. So folks, in one of the things I've been looking into as just a personal interest of mine as a way to better host and moderate this show is how to do a better job storytelling as it relates to everything I do personally with the Bright Spots business. And I stumbled upon a book called Sell with a Story, and I started reading it and I just fell in love with it. So I reached out to the author because I see there's so many, it's so applicable to healthcare. And that author has agreed to come on the show, and we're going to record the episode next week, Thursday at 9:30 a.m. I know that's not East Coast time, not convenient for our West Coast and Mountain Time friends. But I was just going to record it and drop it into the show. I want to get your feedback through a poll. If we were going to make that interview with me and Paul Smith live, and we're going to talk about selling with a story, how to sell into health plans and providers using storytelling. If you were going to attend that live via Zoom, if you would want to come to that. So not sure we're going to do it live, but if I get some feedback today that you would want to come to that live, we'll record it live. Paul agreed to do it live at 9:30 if you guys are interested. So Sherry will put up a poll. We'll get some feedback from you. Gene, tell me about now maintaining adherence to those appointments you just referenced, and what do you mean by referable moment? It's come up a couple of times throughout today's conversation.
Great, thanks, Eric. Adherence is a real issue, whether it's pharmaceutical adherence, people getting prescriptions and not filling them, or people getting appointments and not going. The problem is if there's any barrier in the way, people will not do it, or they will have trouble with it. And so one of the things that we found is that if you're able to schedule at the moment in time when a patient is actually thinking about going to the doctors, is ready to accept that they need a referral, that the likelihood that they'll actually show up can double, triple, quadruple, because they now have an appointment, they have a time, they have a social contract, they've accepted an appointment, and then we do all sorts of things to remind them to go. So we realized that there is this concept of referable moments. So we actually trademarked that. And it's really our battle cry, if you will, because if you can schedule people at that moment, the likelihood that they'll go is dramatically increased. If you try to catch them later to schedule it or have them call back on their own, it doesn't happen. And so we find that there are lots of referable moments when people get a home test and they have a positive result. They're going to cancel the rest of their day if they think they might have colon cancer to try to find a doctor, and it might take them 2 hours. But if you could schedule that gastroenterologist at the same moment you're calling the member saying they have a positive Cologuard or FIT test, you have done a real service to your patient, and you've really gotten them to be able to get that test done without ruining the rest of their day. So that's the referable moment. That's our theme.
I like that. I like that a lot. And it seems to be an important, especially if you could put like quantifiable metrics tied to that, to say, it sounds like everyone should be focusing on that referable moment, whether they're using ReferWell or not.
That's right.
Incidentally, folks, when you provide that feedback, if you want to meet Gene or members of his team and just pick their brain on how they do what they do, I'm happy to make a personal introduction to them. So real warm transfer if you just want to pick their brains. So I want to talk about the last 10 minutes here, the core components to building a winning program as it results to equity and access. So Brenda, let's bring you back in. Could you tell us a little bit about, we haven't talked a lot about pharmacy and medication adherence and refills. How are you with the underserved in New York City providing better access to prescription refills?
So, I was really smiling.
Hey, Brenda, we have lost you. Could you, I don't know. I'm going to wait for you to come back. I'm going to ask another question to keep us moving and come back to you. Gene, since I know you got the audio going, let's talk about blueprints. So for the folks listening and they want to go back to their office and have a high level kind of plan on how to enhance their plan for more equitable access, what are like 4 or 5 pillars or components you would list for them that they could go back to the office with?
Yeah, great question, Eric. Obviously, data, understanding your population, understanding who needs to help the most. I think the second major pillar is leverage every tool you can get. I wish I had in the 90s when I was running health plans. I wish I had some of the tools we have today and some of the metrics we have today. The technology is incredible now. So leverage all the tools you can to more effectively reach your population and actually get them to go. So scheduling, we just believe, is a really important component to get them to go. And then make those tools widely available. Make them available to, if you're using care navigators, your own care navigators, make those tools available to them. If you're relying on network partners like Network Health, provide the tools to them. Make sure they're universally usable. So they're EMR agnostic. If it only works on, one EMR, you're only going to get, 5% of the market using it. And then actually this might go against the grain for some health plans, but make them payer agnostic, because, a lot of your doctors, they don't all see just your members. They see lots of other members from other health plans. And if the tools are payer agnostic, they're more likely to adopt them because they don't have to use one tool for one health plan, another tool for another health plan. They can use one tool for all their patients in all their health plans, and it will help you. So anyway, I think just use the tools, use all the tools available and make them widely accessible.
So I heard 4 things there, but please correct me if I'm wrong, because my wife and parents won't believe me if I get 100 on this. So I'm due for getting one wrong. Scheduling capability, you need to have that in place. You need to make it widely available to the team of internal and external partners. So both your case managers and your navigators, but also the partners that you work with, your provider partners and your health plan partners. 3, it's EMR agnostic, makes sense. And 4, and this is the big one, it's payer agnostic. Don't worry about the fact that maybe you're one of 3 dominant players in the market. Give it to your providers. They're more likely to use it that way. Have a good feeling about it. So make sure it's a tool that they could use for their entire practice. Those are the 4 things I captured while you were talking there.
Eric, your family will be glad to know you got 100% on that.
Woo-hoo. Awesome. Let me thanks for that. Let's go back to Brenda and see. Do we have your audio back, Brenda?
Take 2. Can you hear me?
Yeah, take 2. So let's talk about pharmacy refills. New York City. How are you providing adherent, making sure people are taking their meds and getting refills for the underserved in New York?
One of the things, especially with the Medicare population, I was really smiling ear to ear when Jean was talking about the referable moment. We think a lot about human behavior, what point of human behavior you really need to intervene, and what the mechanisms are that you need to use to intervene. And what Jean was saying really reminded me of the Google kind of moments to buy kind of philosophy. And for us, I come at it a slightly different way. If someone cannot get an appointment to get their refill, what do you do in that instance? And that's when telehealth is a fantastic opportunity. But if you're looking at telehealth with the existing physician as your only avenue, that's probably limiting. We do know that according to our CAPS data, especially with our Medicare members, the number of people that have tried telehealth has now gone from about 30 something percent self-reported to 50+%. So we're seeing that there is some openness in the adoption, but what we were able to do with our partners that we use for 24/7 access to telehealth, we were able to create a campaign that was really cohesive between ourselves and our provider partners that create the 24/7 telehealth. We were able to create a campaign that was a one-time refill opportunity, of course, with its set limitations. And now that is something that we can sell as a simple, or engage using that as a simple.
We lost Brenda again.
I was lost again.
There you go. Go ahead. I think the last thing we said was engaging, and then you literally got cut off. Go ahead.
Yeah, so really using that opportunity to engage with our members with a one-time prescription refill. That has now really become one of the areas that we are not just using for Medicare. We can use this across different populations to really say, hey, maybe get over the discomfort of trying a different kind of mechanism, trying telehealth. And then they're also able to get something that's of value to them, which is that one-time prescription refill. And then this way, we're also using an avenue to really close the digital divide as well. And I think a lot of that is the kind of resistance to trying something new. But as we're seeing kind of the value proposition that we're changing with something that they really want to do, which is maybe get their refill, we're trying to tackle it from that angle.
Love that. That's great. I know we only have about 2 minutes left. Elizabeth, what I'd like to get from you to close us out is specifically, I'm big about a culture of empathy and how health plans are really innovating in that regard. And sometimes it's simple stuff that drives innovation. Can you talk a little bit about what's going on at Network Health as it relates to getting every employee more exposed to CBOs and just overall what Network Health as an organization is doing to inspire volunteerism?
Yeah, thanks, Eric. Our chiefs, vice president, leaders, and employees are all living our mission to build strong and healthy Wisconsin communities on a daily basis. Every employee at Network Health has 8 volunteer time off hours that they can use in our communities. And they are engaging with our community-based organizations through Network Health sponsored activities and on their own In particular, looking at communities where we have high ADI indexes to ensure that we're collaborating with organizations in those communities, serving our members and Wisconsinites. An example of something that we've done is looking at our local farmers markets. And we're in attendance with our employees at farmers markets across the state throughout the summer months. Winter, we don't have a whole lot of farmers markets here, some indoors. But we go to the farmers market and we bring forth healthy recipes tied to the produce that is available at the farmers market to help people learn not just what to buy at a farmers market, but how to prepare the food as well. One of the other things that we're doing, and I think, Jean, you mentioned this earlier, is this is really a community effort. You know, this isn't a network health effort. This isn't a priority health effort. This is all of us coming together to help all boats rise together from an equity perspective. And so we look at other organizations and other managed care organizations and see ways that we can partner with them. So, for example, we're working with a long-term care organization in our state today where we're providing the primary and acute services. They're providing long-term care, and we're collaborating to identify a quarterback that can be that high-touch person with the member who can help that member navigate with us from a primary and acute perspective, ensuring they're leveraging their supplemental benefits and benefits that they can use to address social determinants of health needs, but also making sure that we're really getting that whole person care for the member. And as Allie and Brenda said, making it easy for them, making this easy for the member so they don't have to think about it. We're helping them to empower them and engage them in their care in that way. And what we're seeing when we engage in this type of work is increased HRAs being completed, increased annual wellness visits. Members really appreciate the collaborative approach. And, you know, for us, I think that the key point being is that health equity isn't about the efforts of one person. It's not one department. It's one organization. This is all of us on this call and all of us listening in on this call, working together to best meet the needs of the people who need us most. So we're very, very fortunate that we have that engagement at our organization.
Well done. Thank you to the four of you for all the work you put into preparing for this and your participation today. Thank you to everyone listening and for the time you've taken to listen to the show. Remember, the success of innovation is largely affected by what you do and how you do it. And you've got some great ideas. Hopefully it inspired you to bring them back to your organization, find a bright spot and close it. This is your Bright Spots in Healthcare podcast, everyone. Have a great rest of your day.